The most common disabling injury of the stifle joint in dogs is a cranial cruciate ligament rupture with or without concurrent meniscal injury. Other disorders of the stifle joint include osteochondrosis dissecans, caudal cruciate rupture, collateral ligament tears, meniscal injuries, synovitis, and patellar luxation. Osteochondrosis dissecans is a failure of endochondral ossification leading to cartilage retention. This retained cartilage yields to underlying fissures. Full-thickness cracks may give rise to cartilaginous flaps, hence the term osteochondrosis dissecans, which may then become detached and free-floating within the joint as a joint mouse. Though most cases present for a unilateral lameness, it often affects the dog bilaterally. Radiographically, OCD appear as a defect in subchondral bone, and radiographs of the contralateral limb may be helpful for both comparison and/or diagnostics. OCD lesions can be quite large and are often identified interoperatively in situ, requiring elevation for removal. It is important to remove the entire lesion. Remaining hyaline cartilage may give rise to joint mice. Joints most commonly affected by osteochondrosis include the shoulder, elbow, stifle, and tarsus. Surgical intervention is appropriate for any joint presenting osteochondrosis dissecans in order to remove the cartilage flap and provide fibrocartilage ingrowth within the defect. A chronic degenerative process or a traumatic event resulting in acute failure causes a cranial cruciate rupture. These two etiologies may be interrelated in that chronic degeneration may give rise to a partial rupture of the ligament, and then an acute episode of complete rupture ensues. The etiology of CCL rupture is not fully understood, but theories center around an immune-mediated disease, conformation, or inherent weakness of the ligament relative to the forces placed on it. CCL injury tends to segment in four categories. 1. Small or toy breeds where it may be secondary to medial patellar luxation. 2. Large to medium-sized dogs suffering acute traumatic injury. 3. Young large breed dogs with conformational abnormalities such as narrowed intercondylar notch and increased caudodistal tibial plateau sloping. And 4. Middle-aged medium to large breed dogs whose immune-mediated osteoarthritis or genetic factors incite CCL damage. Hind limb lameness in dogs is frequently associated with cranial cruciate ligament ruptures. Risk factors include poor conditioning, abnormal conformation, excess weight, immune mechanisms, aging, and trauma. The cranial cruciate ligament is the primary restraint against joint hyperextension and cranial movement of the tibia. It also limits internal rotation of the tibia and prevents excessive varus or valgus motion of the tibia in the flexed stifle. With aging, the CCL undergoes degeneration, characterized by loss of normal fiber bundle morphology. The degenerative process is most severe in the central core of the ligament. Integrity of the ligament is compromised and it ruptures under stress. A CCL rupture, as well as other degenerative joint conditions, routinely cause synovitis, an inflammation of the joint lining. Typified by neovascularization, capsular thickening, increased joint fluid volume, and poor quality of the joint fluid, synovitis is associated with severe pain due to capsular distension and periarticular inflammation. Within the joint capsule are the medial and lateral menisci, as well as the anterior and posterior cruciate ligaments, all bathed by synovial fluid, a clear and viscous fluid in the healthy joint. Normal articular cartilage is smooth and pearl-like in appearance, with a white and glistening look. The synovial lining of the joint capsule also appears white and relatively smooth. As the cartilage becomes diseased, it loses its integrity and becomes soft, eroded, and begins to split. In turn, the neighboring synovial lining of the joint capsule becomes increasingly vascular with numerous villi, a condition known as synovitis. Further, the synovial fluid turns cloudy and less viscous. Synovitis becomes more pronounced, and inflammatory mediators invade the joint fluid. Osteophytes develop, often at the interface of cartilage and joint capsule, where their presence further irritates the sensitive synovial lining. Joint capsule fibrosis and thickening result in a decreased range of motion and pain. They also contribute to the stiffness typically associated with clinical signs in the osteoarthritic patient. Patellar luxation, a condition varying in severity from grade 1, mild with minimal clinical signs, to grade 4, permanent luxation of the patella with severe lameness, may be lateral or medial, is most often congenital, and is associated with varying degrees of femoral and tibial deformity. The underlying cause is a defect in pelvic limb conformation, specifically the extensor mechanism of the stifle. Without proper seating of the patella in the femoral trochlea, trochlear articular cartilage fails to develop with a groove and subsequently degenerates. This trochlear groove may actually become convex rather than concave. Patellar luxation varies from complete irreducible luxation of the patella with variable lameness to mild instability with minimal clinical signs. The luxation may be lateral or medial, and the cause may be traumatic or developmental. Ultimately, chondromalacia, an eburnation of the patella and trochlear ridges, can develop from the constant luxation. To identify patellar luxation, observe the dog at a walk and a trot. Although the gait may appear normal most of the time, the dog may become lame, then kick its hind limb into extension, and thereafter no longer be lame. The dog has become lame from loss of anterior stifle support as the patella luxates. He has learned that a sharp extension of the stifle will pop it back into place and once again provide weight-bearing support. During physical examination, check proper alignment of the tibial tuberosity and attempt to manually luxate each patella. Although there are hundreds of reported surgical treatment options to repair a CCL rupture and other conditions within the dog's stifle joint, they can be broken down into three types: extra-articular ligament prosthesis, intra-articular ligament prosthesis, and anatomic alteration of the stifle. As mentioned earlier, the cranial tibial thrust (CRTT) test helps to diagnose a CCL rupture. After diagnosing the damaged ligament, tibial plateau leveling osteotomy surgery provides an option to stabilize the joint. Because of the caudodistal orientation of the slope of the tibial plateau, tibial compression during weight-bearing or tibial compression test generates a cranially oriented shear force in the tibia that induces cranial tibial translation in the stifle joint following a loss of the cranial cruciate ligament. This shear component of the compressive force at the stifle, termed cranial tibial thrust, is opposed by the cranial cruciate ligament and presumably by the caudal pull of the hamstring and biceps muscles on the proximal tibia. Therefore, a cranial tibial thrust can be elicited with a ruptured CCL. Tibial plateau leveling osteotomy, known as TPLO, is one of several surgical techniques for managing a torn cranial cruciate ligament. This technique reorients the caudodistal orientation of the tibial plateau slope to a more level position, thereby providing functional stability during weight-bearing. A precisely determined crescent-shaped osteotomy is made in the caudoproximal portion of the tibia. The proximal tibial fragment is then rotated a predetermined amount so as to create a more level tibial plateau orientation. Once the fragment is determined to be correctly rotated by alignment of predetermined reference marks, the tibial fragments are stabilized in the desired relationship with a specially designed patented bone plate. Unlike traditional approaches, this osteotomy procedure does not attempt to restore cranial cruciate ligament function, but rather provides functional stability during weight-bearing by reducing the cranial tibial thrust. Because the magnitude of the cranial tibial thrust is proportional to the slope of the tibial plateau, The cranial tibial thrust can